of this today, which is unfortunate, I guess, very timely with the Florida shooting, and I just heard there was two people killed at another college, I think, just this morning. So there's a lot of bets in a dorm room situation. So there's a lot of this violence out there, and most of it is actually not tied to mental illness. But that is you wouldn't know that if you watched all the streaming news channels. So there are.
I don't think
this doesn't work.
Remote is working.
It's not.
Hang on.
Okay, hang on. We're trying to advance slides here.
Maybe.
Or not.
Or, hang on, Doug.
No
I'm
problem.
working on it. See if it works now.
There we go. Oh, well, at least it's on. So
Well, does it?
Aha,
Okay.
we got it. Good, thank you. Okay.
Okay.
So I'm going to give you just a couple of slides of some of the reasons that people, that is human animals, are violent. One is about revenge. It's a theme of many aggressive movies and so forth. You know, something bad happens, the person is emotionally harmed in some way, usually because somebody else they care about was harmed or killed, and then there's revenge. A sense of justice driven by rage generally, and it is certainly a high-level reason that human beings tend to get violent. We may get violent because we think our freedom is being taken away, and whether either in reality or we believe that. We may get violent because we fear we ourselves are losing control, or we may even have a bad day at work and go home and kick the dog. They call that carryover aggression. That is part of the fuel for what is a lot more prevalent than we believe for domestic violence. And so that's another piece that gets into play here. I'll jump forward. You'll have these slide sets available. The number one on this one, to defend, change, or establish a reputation. I witnessed that a lot firsthand when I used to moonlight at Toledo Correctional, which is a high close security prison in Toledo. And what would happen is somebody would come in as a new inmate, and as soon as they were picked on by any person, which was not as common as the movies make it sound, but if they were picked on, they would fight. And it wouldn't matter if they were the smallest person on the cell block, or the pod as they call them there. They would fight, and the point was to establish the reputation that you're not going to be somebody to be messed with, and that in fact, even though, hey, I'm smaller, you still may get hurt. And that would establish a reputation, kind of like the cartoon. And actually, it's some interesting way in that culture would set the stage for a lot more peace within that pod after that one event. Self-protection, or protecting your loved ones. We even have laws that under certain very discrete circumstances, you're allowed to defend yourself, including shooting somebody who comes in your home if they're coming toward you, not if they're running out the door. But there's lots of laws around allowing us as humans. We do recognize, even under the law, that we are violent animals and that we can do stuff. I'll jump down to wilding, which has to do with group violence. This is one of the concepts in gang violence, where we are social animals. So not only are we animals, we're social animals. We need to belong. And all of us are old enough in the room to think back to middle school, high school, maybe even college. There were cliques and people were trying to figure out where they fit in and so forth. Well, if the only place you can fit in is a gang, you may very well decide that's the place to fit in, and then you will do behaviors that require you to be in the gang, which may be terribly violent behaviors as part of the ritual, and maybe even part of maintenance of membership in a gang. And then finally, and really I do this in this order on purpose, we may be violent because of our thinking or our judgment being impaired. And of course, if our perception of the world is altered by mental illness, maybe even by addiction, then any of the ones I've already listed, and there are many others, we might believe those are going on. We might believe our freedom is being taken away and act out violently because our perception is off. So that's where the mental illness component tends to come in. I'll talk specifically about a few of the mental illnesses here in a moment. So we tend to categorize, for many, many years, we categorize violence in two categories. I'm going to give you a third category in a moment. But affective or emotional violence, and this is the one we've heard the most about: fight, flight, and we've really in the recent decade added freeze to this. It's the reason we train law enforcement and military personnel so heavily, so that when they are in a bad situation, they don't freeze, because that clearly is not adaptive you're not going to generally survive terrible situations if your reaction is to freeze. Most of us automatically, autonomic nervous system kicks in. We go into fight or flight mode. The blood rushes to our muscle system, leaves our digestive area. Our eyes dilate, so we take in more light. Our ears become more acute in terms of their ability to hear sounds, and we're on. We are ready to fight or to run. And again, some people, unfortunately, that system floods them so fast they freeze and sort of a state of shock. The other type of violence is predatory. And I'm going to use an example of a cat here. So in the first example of affective, if you were to corner a cat, even though it might have been passive at that point, it may start to hiss, it may start to scratch at you. That would be an affective, emotional, defensive type reaction, the fight or flight response. And again, all mammals carry that ability. Predatory for the cat would be the cat you see very slowly crawling across the lawn. And then if you look at the whole scene, you realize there's a bird on a low-hanging branch. And the cat is stalking, predatorily trying to go up and use violence to kill the bird. And of course, humans can get into this mode for various reasons, one of which may be they have persecutory or paranoid delusions. And in this type of violence, it tends to be more planned. It's not a reactive type of violence. It's a planned out violence. And that can occur, of course, for many of the reasons I listed: revenge, perceived revenge, if it's a mental illness, and so forth. The other violence that's really new, probably since about the time of MySpace, which predates Facebook, is where people attack each other in a verbal type setting, and people tend to pile on. So somebody posts something negative about a person in their high school class, and then 5 other people start attacking them verbally, and they call that a social violence. And it can be very damaging, and that type of violence we've seen in the background of actually some of the school shootings. We've seen that those can be tied, that really drives people to a level of many of those reasons they might consider being violent. There are some studies that are new on this. Some of them are seeming to tie it to higher testosterone levels, which is an interesting concept, because in the beginning, a lot of the social violence was actually more female on female. So there may be that females with more testosterone, so the jury's out on this, but just to give you a little bit of possible science behind it. And then, of course, unfortunately, as I said, timely, we've had a lot of violence. Mental illness gets tied to some of this across the country. This slide is actually probably 2 years old, so there are more events, such as the Florida event, would add another red dot, unfortunately, there on the map. This is from the magazine Mother Jones. They actually came out and talked to us at the Summit County ADM board and a few other places around Ohio, I think around the time of the Chardon shootings, which is what brought them to Ohio, unfortunately. So terrible, terrible situations. They get a lot of media attention, but there are many, if you will, less victim type situations that occur on a seemingly increasing basis, although the statistics actually, if you look at it, is that it has not gone up. It's more that the media plays it over and over and over again, so we perceive, using that word again, we perceive that it's worse. So a little bit of biology. We know, again, we are animals, and so we have to look at the brain structures here, and we know that basically there's a balance between our cortex of the brain, the orbital cortex in particular, and then the anterior temporal lobe, where we process all this stuff. So we're bringing information in. We are driven at some level to be aggressive in certain circumstances. And if we can balance these two areas of the brain out, which most of us do most hours of most days, and some do that their entire lives very successfully, then they're in balance and we don't tend to end up being aggressive. This is why laws work, right? We're thinking about, ooh, I don't want to do that. I'm feeling angry because the guy just cut me off for the 3rd time in the last 3 minutes, but I don't really want to get into it, and I might get in trouble. I might get hurt. There might be legal consequences. So we are able to balance those things out and ignore what starts maybe as a fight or flight response. We get an autonomic reaction to that kind of affront. So that's one process that we look at. The limbic system, no surprise, is the big one here. Again, mammals share this. So we have an emotional response system. We work a lot with that in the behavioral health arena. The amygdala is the one that gets the most stage time tied to aggression. And so other parts of the brain can be then connected to the amygdala. We know there are certain circumstances where somebody has both temporal lobes removed, or they get damaged by an encephalitis or some such process, and that leads to what's called Kluwer-Bucy syndrome, where these individuals become very changed, because they've lost these aggressive sort of sets of the brain, and they're maybe tame, docile, and so forth. We know that we can increase stimulation of the amygdala and increase aggressive behavior, so that's why we tend to tie to that. And a very famous case from my forensic interest was the University of Texas sniper, Charles Whitman, way back in 1966. And nobody understood what happened. He ended up in the Texas Tower. He was shooting with a rifle. He did kill some people. It was not an assault rifle, in which case it might have been worse. But he was shooting. He did kill people. And nobody understood it. He was not somebody anybody expected to do this. When they finally did the autopsy, they discovered he had a big tumor pressing on his amygdala. And in fact, there's even some speculation that the guy who did the shooting in Las Vegas might have possibly had something like this going on. Unfortunately, he killed himself by shooting himself in the brain. So I suspect evidence was lost, if you will, of that. So we still don't know what changed that otherwise apparently well-to-do individual. So then, of course, going down to the smaller molecular level, we talk about neurotransmitters in the brain. The most commonly researched is serotonin. That's the one that we first had medications to really increase in a big way when Prozac came out as a selective serotonin reuptake inhibitor. And we know that low levels of serotonin are tied to depression. They're tied to anxiety. They're also tied to aggression, both towards self and others. So it's a big interest in the forensic psychiatry arena. People tend to be more impulsive. And then what really happens is without enough serotonin or that system being in dysfunction, we end up with this disinhibition of excitatory systems. So it drives a whole cascade of events in the brain. People become more irritable, and then they also don't do as good a job of that balance I talked about in one of the earlier slides in terms of controlling their thoughts and their impulses against balancing that with societal norms and so forth. So that's a problem. Researchers get very sophisticated with this. They can actually create mice, knockout mice, which is a phrase used for many types of mice when they change something about the mouse. They can knock out a particular serotonin receptor, the 1D receptor. And when you do that, again, now that means you clearly have a hypofunctional serotonin system. They end up with increased aggression in those mice. I think there was one of those versions of that. There was a rabbit in Monty Python series that probably had that same problem. If anybody remembers that movie. Then, of course, we look at people that have a history of impulsivity, and that often is then correlated, at least highly, with violent behavior. And when we research those people, criminals, again, arsonists, particularly violent types of suicide, if you do research on them after the fact, you find out that they had low levels of serotonin, or at least the metabolites of serotonin in their cerebrospinal fluid. So I've mentioned this. Humans are social animals. So nurture is the other component. We have the genetic components, and sometimes there's truly something genetically wrong, maybe from the beginning with the serotonin system, or maybe other systems, maybe the amygdala. And so as social animals, we have to have bonding from a young age. Most research is focused on maternal bonding, but there's a lot of research growing now about the role of fathers and maybe even early bonding there. We need to belong, as I mentioned. Somebody who's truly a loner, there's probably something wrong with that individual. Maybe a schizoid personality disorder or something like that. We need social support systems. We're exposed to modeling, and we ignore this because in a lot of ways it's not imprinting like ducklings, but modeling is powerful. If we think about it, during the first year in particular, and certainly the first couple of years, we're not yet able to really put things and store them verbally. We can't make sense of the world that way. We are observing constantly. Using my inmate analogy, what inmates have that the officers and others don't in that setting, or myself as a psychiatrist, is they have countless hours to sit and watch everybody. They are become very good at reading people and understanding people that are around them. And so they're watching different modeling as well. And there are some prisons where the right modeling actually helps decrease the violence if you can model that from the warden on down. But for kids growing up, this is very, very powerful. And of course, this is where the cultural piece comes in. Some behaviors in one culture may seem odd or even be diagnosable in another culture. So we have to be very careful about what we do around cultural sensitivity and awareness. People need daily structure. All of us in the room and in the Zoom, we work hard and we crave that vacation, as some of our kids probably today happily craved and got their snow day. But if that happens suddenly and you can't be functional because you lost that daily structure, we do not do well as humans. And I think we see that even through Hollywood. They work really hard for 6 months, and then they have all this money, and then they got a year and a half of nothing. They don't do well. That's the subject of tabloids and all these other problems. And we need a purpose in life. So we don't have these things. This is not genetic per se. This gets more into the nurture. If we don't have that, that also can be a problem for violence. And this is just a sort of a funny version of nurture. It says some kids at school called you a feminist, Mom, but I punched them out. And I put this here because how the parents react to this event may change how violent this, I assume it's a girl, it's hard to tell in the picture, but probably from the shirt or the blouse, I guess you'd call it, as a girl. If the mother says, good for you, honey, let me teach you some better ways to punch, that's a different response than, hang on, let me put the paper down as the father in the background, and let's talk about what happened and how we could have handled it differently, right? So how the parents respond to this is going to make a difference going forward. That's a nurturing thing. That's not about genetics. Or maybe you could argue it's somewhat genetics because the parents may have certain tendencies and the daughter therefore may have inherited them. So we believe violence is nature and nurture, and generally it requires a bad combination of both to really lead to particular violence. We know there's some violent genes that are being discovered, some dealing with monoamine oxidase A. Damage to certain brain areas we know seems to be highly correlated with violence. Trauma, there's a whole movement around trauma-informed care because we know that that affects lots about nurture, and of course combined with bad nature, if you will, with certain genetics can really be a problem. And then the bonding piece. The bonding one is very important, I think, now, because we're seeing a lot of children born addicted to opiates, and some of them have neonatal abstinence syndrome at a level where they need to be in a NICU, neonatal intensive care unit, and those children don't then bond very well with their parents because they're in this little isolette, often with leads on them, reading their blood pressure and pulse and so forth. And so I actually personally, as a psychiatrist, have a concern about that. We have yet to see the outcome of that since the epidemic hasn't been so strong for 18 years. So these children being born, who knows what that lack of bonding will lead to as we move forward in time with those individuals. And then, of course, just the cautionary here with research, so far it's correlational. We don't really have great cause. We might be able to argue that stimulating the amygdala leads to violence is pretty causal. But other than those types of really basic science research, the rest is problematic. Because we tend to focus on children and adolescents, I wanted to mention the impulse control disorders here. We hear a lot of people saying, oh yeah, the child's got intermittent explosive disorder. Probably not. That's actually very rare. And I'll give you an extra slide on that in a moment. We have other types of impulse control disorders, kleptomania. We've got good research showing that's not about money. In fact, we've heard about, I think, Lindsay Lohan and some other wealthy people who can't stop this impulse to steal. They clearly could afford to buy whatever it is they stole, and they can't help themselves. Pathological gambling, huge issue. And of course, it's gotten worse in some respects because as a society, we seem to have decided that gambling is a great way to bring in money. And therefore, we've opened up more and more casinos and more scratch-off lottery tickets or what have you. So that really is another issue that probably isn't the right direction for society when some people do have that impulse control disorder. Fire starting, another big problem, obviously, especially if people get injured from it. And then hair pulling. And there's several versions of this. It doesn't have to be hair. These types of disorders where you're picking at your skin, you're pulling at your hair and so forth. So intermittent explosive disorder, the real issue here is that when people look at the case very carefully, they cannot find a trigger. If there's a trigger, it's not intermittent explosive disorder. But if truly the child just suddenly becomes extremely aggressive, and you can't seem to find any true solid precipitating psychosocial stressor, then that's when we start to make this diagnosis. It's an effective diagnosis. And you'll notice, though, that by the time we get to that, it's usually not in young children, even though that's who tends to get labeled. Usually, if we look at them very carefully, we can figure out what this is, what the triggers are, and work with them. Although in this echo series, we tend to hear very challenging cases where maybe it's a little harder to figure out which of the many stressors is leading to these behaviors for the people we hear about. And so, sort of in conclusion, I'll just mention some real good research here. Monahan did a very large study. I think it was over 10,000 people, and showed the things that we often talk about. One, that men are 10 times more likely to be violent than women, but also if somebody has mental illness or actually intellectual disability, that gender difference melts away. It's as though it's an equalizer. For some reason, in effect, mental illness makes women so much more violent and men also more violent that they end up becoming more equal. That's rather interesting, I think. Younger individuals tend to be more violent. We tend to get less violent as we get older. That may be tied to testosterone. It may be tied to more nurture, if you will. We've had more psychosocial interactions over year after year after year. We kind of learn, call it wisdom, call it what you want, but we just don't tend to act out aggressively the way we might have. Any instability in life tends to be a problem. And of course, the biggest predictor of future behavior is always past behavior. If I tend to always get violent every time somebody says something negative to me, I'm pretty likely to do it again the next time they say something negative to me. And vice versa. If I'm always pretty passive, we all go through life stressors, and my coping mechanisms tend to work, you can pretty well predict that the next time I'm stressed, I'm going to cope reasonably well, I'm not going to become violent. The biggest predictor, actually, of violence is alcohol use and drug use, apart from the history of violence. And we'll talk a little bit more about that. If you drive down on these, some of these are not rocket science. There really is research that says if you say you're going to hurt somebody, there's actually an increased likelihood you're going to do it. And if you say how you're going to do it and who you're going to do it to, then that risk goes way up. So we really can't just ignore that type of information. Some of these are already mentioned, but kind of drilling down toward the psychiatric disorders, impulsivity, which can be a part of many disorders because they're affecting your brain and your judgment, psychotic illnesses, any axis 1 diagnosis, and interestingly, the research was parsed pretty well. Even things like panic disorder and OCD increase your risk of violence. It's not, in quotes, just schizophrenia, which is what the public always hears about, or depression, but seems to get lumped into that for some reason as a increased risk of violence, which I'm not convinced is necessarily true. And then certain personality disorders, antisocial personality disorder, about 50% of people end up in prison, meet criteria for that, but not 100%. The public tends to think it's all of them. That's not true. Borderline personality disorder, brain injuries that I sort of loosely call organic personality disorder. It's not really in the DSM-4 or 5 for that matter, but there's certainly brain injuries, soft neurological signs we could find that change personality and lead to these types of things. No surprise if you've got a history of hospitalization that you're probably pretty ill. It's hard to get into a psychiatric facility unless you've got some reasonable illness or at least emotional imbalance going on. If you've got a family history, that gets more into the nature as opposed to the nurture, but also nurture. If you grew up in a household where mental illness caused more chaos in your upbringing, that also then could be correlated with your future mental illness and or violence. Already mentioned brain injury type things, and then the intellectual disabilities issue that seems to basically equalize men and women, but both go up in the risk of violence. Drilling down further, certain types of illnesses. We know that individuals with schizophrenia, we don't exactly categorize it like this in DSM-5, but if they have first-degree delusions, they tend to go after the persecutor, and some will plan it out so they get them before they get got. That's where we get very concerned about serious types of violence. If somebody has more of a disorganization around schizophrenia, they tend to have their violence more of an inpatient setting, where they're perceiving that their freedoms are being taken away. They can't verbalize it necessarily. They're not reading the world correctly. That's where they tend to be more violent, not running around amok in a crowded Walmart or something. That's not very common. Command hallucinations, very serious. If we have a history that the person has complied with the voice, then we have a much bigger bar to worry about as far as if they get a voice that tells them to hurt themselves or someone else, they're more likely to do it at that point. Some people don't respond to these voices very well. They're able to set it on the side and realize it's not a real voice. But we do know from research if the voice is familiar to them, a dead grandmother, or if they're religious, God's voice, they may very well act on that voice much more likely than if it's some random voice they can't quite figure out who it is or what it might have been. Delusions have a higher relation to violence than hallucinations. So if you believe people are out to get you, you're more likely to act out violently than if you're hearing voices or seeing things that others aren't seeing. And then we can drill down on types of delusions, paranoia, as I mentioned in particular, perceiving that forces are taking control of you. These are individuals you'll see that may put on a foil hat or do other things, block their windows, doing things to show, gee, I'm trying to stop this. I really don't want to get violent. I really want to just be let alone. Stop bugging me, but they can act out, of course, violently if none of those things work, which they won't, of course, because it's all coming from within and not from without. Erotomania is another interesting one where the individual believes that somebody is their supposed to be their love object, their wife or their husband in general, tends to be directed toward people either on TV, in the movies, or in uniform. So law enforcement personnel, paramedics, and military. You've probably heard that David Letterman for years has had a female who has stalked him. She clearly has erotomania. She's even managed to break into his home, which I have to believe with his kind of money would be reasonably secure. So that's pretty persistent to be that ill and to be driven. And my belief was she probably would be diagnosable with something like erotomania if we were to actually have a chance to assess her. Mania, just drilling down a little bit more, and then we'll leave time for some questions. Highly assaultive and threatening, but they don't tend to be seriously violent. They're not planning violence, but they do have this larger sphere because their mood's expanded, maybe irritable, but generally expanded and on top of the world. So if you try to limit them, set limits on them, they may act out violently. So that's what we see in the hospital setting sometimes. Major depression in general, people with depression, they get to the point of what we would call despair. That's the word we kind of talk about when people are now at the point where they may actually try to take their own lives. Then they may also at that moment act out against others. We do occasionally see familicide where it's more often men than women where the husband ends up in that despair and kills the wife and the kids. Not common, but that tends to be tied to this level of despair. And then certain personality traits, as I mentioned, no surprise, reckless, impulsive, those types of people that have a external locus of control where they believe that what's going on is all outside of them and I'm fine, but it's everybody else. They very well may act out against everybody else in that circumstance. Situational factors, no surprise. If you're in a setting where people encourage or incite violence, that's the family or a peer group, the environment. If you're unemployed and or lower education, lower IQ, and lower education are both correlated higher with more violence. And I'll just give you an interesting example here. The difference in a level of violence between somebody with a college degree and a high school degree, that change in difference, which is lower for the college degree than it is for the high school degree, is the same amount of difference between somebody with an active Axis 1, as we used to call it, mental illness, and somebody without it. Not that much is the point. We publicly believe it's this huge gap, but when you do the research, that is about the same change in violence risk. That is not to say there are not some people with serious mental illness who clearly can be very violent and dangerous. Availability of weapons, we have to mention, not to get into a gun control discussion, but clearly if you have weapons training, because you formerly were law enforcement or military or currently are, that raises the risk because, of course, if you use a weapon, you may very well be able to use it effectively, more so than somebody who has never picked up a gun but happens to get one from their grandfather's closet they forgot was there or something. And then again, there were social animal component. If we don't have supportive, healthy relationships, that's a problem. Childhood factors, real quickly here, correlated. No surprise, I guess. These are, kind of going against societal norms, truancy and delinquency. If you've been assaultive, then, you've already shown your violent propensity. Abuse or seduction by a parent, so trauma type things are in there. And then, of course, psychiatric hospitalization at a young age, because now we know there's something going on that's really leading you down that path. This is the final summary slide of violence. Again, a giant study done by Swanson, who's still a very well-known researcher in this arena. I skewed the numbers a bit just to round them so it's easier to remember. But basically the gist of this, again, 10,000 people, I think, in the study, 2% of that group were violent per year without any diagnosable disorder, and they put them through the mill, so there probably weren't any disorders in these people. Note the 5-fold increase if somebody does have an active axis 1, as we used to call it, so schizophrenia, but I mentioned OCD, panic, other illnesses. That's a huge jump. But if it's the person's under treatment, that can drop all the way back down to 2%. So we can actually eliminate that 5-fold increase. Notice, though, that going from the 2% to cannabis use or abuse, now we just call it a use disorder, it's a 10-fold increase, much worse. And people think that, oh, there's nothing wrong with marijuana. Well, there really is a huge increase in violence. And people say, well, but alcohol's worse. Well, unfortunately, yes. Alcohol is even worse. It's a slightly higher increase, but not as much as you think. People assume you're drunk, you're more violent than if you're high with cannabis, but it's not that far apart. And then, sadly, with our opiate use disorder problem right now, 35%. So a huge jump from 2% using other substances. And by that, at the time, they meant heroin, crack cocaine, and so forth. So methamphetamine, I'm not sure how prevalent it was in this study, but that's on the rise as well in this region of the country. So, all right. Actuality, I've mentioned it, not a big relationship between mental illness and violence. Most people are actually victims, if you have a mental illness, than a perpetrator. Victims of people with mental illness who become violent, it's rare. It's rarely strangers. It's usually someone in the home, right? They're angry because their parent is still controlling them or what have you, and that's who they tend to act out as. The Treatment Advocacy Center, you'll get this slide, kind of summarizes a lot of what I've just said. And even with all that, when we try to predict who's going to be violent, it's not always easy. That's a subtle one, but anyway. That's Rudolph on Santa's wall. Apparently, Santa had a bad day.
All right. Thank you very much. I think it was an incredibly timely topic. And looking at some of the actual data as compared to some of the perceptions that are out there. I'd like to turn it over to the folks who have zoomed in for what questions or comments do you have on Dr. Smith's presentation?
Did it make anybody angry?
So if there's nobody that's zoomed in that has any comments or questions about it, the one thing that did come to mind when you were talking about bonding, one of the things that I know that they occasionally do in the NICU with kids that are born very prematurely, so I'm not sure if this applies to kids who are born of somebody who's addicted to opiates, but when my stepson was born very preemie, they had times during the day that both parents were allowed to go in and they do skin-to-skin contact. So my husband would go in and take off his shirt and sit for several hours with the baby on his chest just to have that intimate contact. And so they do try to encourage that in at least the NICU in Youngstown.
Good.
I know here at the Altman Hospital they do that too. In fact, I think there's a waiting list for volunteers to be a skin-to-skin or kangaroo care. But this was just another excellent presentation. Thank you so much. It just came out yesterday in the news. I don't know if you saw it, the young man who was the shooter at Jackson Middle School. This child apparently had a written plan, but was not on anybody's radar screen.
Yeah.
How can, we as primary care, is there anything more that we can do or schools can do to try and identify possibly, these kids who are just gonna, go off the deep end?
I think that's a great question. One of the things that stuck out to me is there are risk factors, but that's not causality. So it's going to be trying to put those risk factors together.
Yeah, this is unfortunately,
Exactly.
it's the similar problem that we have in predicting who may I should say, die by suicide. We're trying to change that word as well. Because these are low base rates. So the idea of if you think about the old tools that give you sensitivity and specificity, which is its own other statistical type lecture, I won't go into. But it's very tough when you have a low base rate. Still too high. We want no school shooters. We want nobody dying by suicide. But when you try to look at that as a population, it's very difficult to come up with what are the more definitive risk factors. And now we do have more stuff in suicide, as we talked about a couple of weeks ago. There are certain what's happening now that we can tie to a higher risk. It's tougher with violence unless you've got a history of violence. So I agree. I did just see that about the Jackson person who ended up dying by his own hand. And clearly, if there's truly nobody, now we don't know. We hear the media. We don't know. As people look backwards, my guess is they will study that and go, well, there were these things, but we also saw it in 20 other kids over the last 2 years, and they didn't do this. And I think that's kind of the nature of your question. Wow, and so for example, in the Akron area, they've tried to use this change direction program where we're trying to teach the 5 signs, changes in people in their mood or their behavior to try to get the public better educated. And there are attempts to do that now more in schools. There's even a version of crisis intervention team training that we use for police that some school systems are attempting to adapt the CITE for education in the school systems to try to help educate, to look for it. The biggest one, though, is the stigma. We need to not hide this stuff from ourselves and from others. We want to believe it's not going to happen here. It won't happen to my kid, and it won't happen to my students in my classroom. And if we broaden that and say, wait a minute, we know this happens a certain percentage of the time, 2% per year without any violence. Well, if I'm in a high school and I'm teaching a bunch of classes, I might have 100 kids. I might have 2 that I should be watching for. And I think if we taught it that way, maybe we'd all be a little more on as educators and other systems to watch for any outlier. Anything that's a little bit different, we should at least address it without stigma. And that, again, stigma is the other bar.
Don, do you think that if we moved away from there being such a criminalizing component of this and more towards getting people help and resources and support, that might be easier for physicians, teachers, other supportive personnel to want to intervene when it looks like there's something kind of teetering? Because right now we do have a situation with schools where if you're not automatically put into a medical category and seen by a psychiatrist for, an ADHD or something, then all other behavior tends to be criminalized. And that's not necessarily the direction we want to go, because then we're increasing their criminogenic risk factors.
Right. No, I think that's well said. I mean, this is the balance. And schools, of course, right now, their bar is we want any outlier out for whatever the purposes are. So I'm aware there was a school after the shooting, the 19-year-old in Parkland, the shooting, some students apparently wrote some letter to his friend, and I'm sure it was in jest, but it wasn't taken this way. It was pretty sad and a terrible way to think, because the list was, well, I hope nobody comes to our school to shoot anybody, but if they do, here's who I hope they kill. Well, that's pretty serious. Now, I imagine there weren't very many people who got that mindset anywhere, in the country. But so we got one person. Well, appropriately, the school flagged that, said, "Hold on, you can't come back to school while we figure this out." And I think that's a little more obvious, because in that case, the good news was it was another student who said, "You know what? There's something wrong with so and so. This isn't good." So we need more of that. We need this. Let's get help, and that was the nature of it. It wasn't, I want this kid kicked out. This was,
let's get help instead of let's put him in jail.
Or she needs help, and let's get the help. And I think more and more systems are working toward that, but it's tough, because there's still a certain percentage of the population that wants to believe it's not a continuum, that it's cut and dry, you have it or you don't. Well, we know all these things are on a continuum, and the problem, especially the question we launched this discussion is, where on that continuum can we more definitively say, aha, this is the risk? And that's tough. I don't think our research is very good about that right now.
So, Dr. Amy, I have a question for you. There's a number of those risk factors that I would imagine you're collecting. So I just jotted a few down. Things like IQ, their prenatal history, family history. Is there a systematic screening that you may be doing looking at those risk factors, or a threshold established to try to that flag some of those individuals?
That's an interesting question. I mean, obviously we try to get, the birth history, all the medical history, but, as a routine, I guess I'm not asking about, I'm not asking about housing or work status, all those other factors that were mentioned. Again, we screen for depression. And if there are problems in school, they tend to come to us, but it's usually, from my experience, been more ADHD issues and sometimes, more behavioral issues. But by then, they've already been kicked out of school because, school isn't going to, like I said, it's not going to deal with it. But it brings up an excellent point that, we perhaps need to be asking more about some of those risk factors. Especially in that population that is prone, these young kids, try to maybe identify something and, before something like Jackson happens.
It just struck me.
But I can't identify a specific screen that I'm aware of. I don't know, maybe somebody has something else. But I think all those questions, we just have to add it to the list of things we need to look at.
It just
so important.
There would be puzzle pieces throughout, but some of the factors I don't think we build on and put them together.
Right.
I very much like the pediatrician that we bring my kids to, but from a screening wellness safety standpoint, she always asks them, when you ride your bike, do you wear a helmet? When you're in the car, do you get buckled up? She asks about family time. So do you guys all sit together at the dinner table? And she has a handful of those questions, but she's never asked about weapons. If there are any weapons in the home or anything like that, which didn't strike me until today, where, wow, that probably should be something that
I would agree.
That could be collected easily. But I think there's lots of the information that's available, and your point is very valid, that how do we do this? We may have it, but it's probably not in a really usable format. I'm wondering.
No, that's interesting because, I'm sorry. At every well visit, I do ask about weapons in the house. So we are, and most of the time, people will tell me that they are locked. And I tell them, good, I'm not trying to be nosy. I only want to know that your weapons are safe. You've got trigger locks or a gun safe. Your ammunition is separate. So yes, we absolutely, my colleagues do as well. That's part of our, standard well child. And most people are very willing to answer. It was very interesting. I don't know if you're aware, just as an aside, that a couple years ago in Florida, Florida legislatures had banned pediatricians and other physicians about asking firearms, about asking anything about firearms in the house, and it took several years before it was struck down as unconstitutional. So thank goodness we can't, because it's important.
That was rolled through the forensic community pretty strongly. There was a lot of terrible reactions to that from the treating point of view, because it just didn't make any sense. You couldn't ask to help people be safe. Some groups, I think maybe Ron, I think even now he's given out trigger locks. I mean, how do we help promote safety?
I was going to kick it off to Jody and Ron, and Bob also. What kind of screenings have you guys seen being done? Because it seems like a lot of the information may be out there, but we're not seeing it all put together. And all three of you have been in very different environments.
Well, I know as far as the screening, I know what struck out to me in your presentation, Doug, was the nurture, the humans are social animals, and that needing of bonding, belonging, those supports and role modeling with appropriate behaviors. And what stuck out with me is that even clinical and non-clinical staff including peer supporters, we each have a role to assist patients and clients in exploring those options. And even in environments such as schools and hospitals or provider agencies, we have a role. Our biggest part is displaying appropriate behaviors ourselves. So if children are in an environment where they're not free to voice and express themselves and they don't feel free to be able to tell the truth or to share that Billy Bob over here is doing and feeling this way, then there's not going to be that openness. And so to me, that empowerment and self-advocacy and role modeling is the greatest tool we can give children today.
Absolutely. I think the role modeling, we all could play an active part. That's a great way to empower everybody to be able to participate in that. Absolutely. Ron or Bob, do you have any other from the places you've been? Oh, Bob, you're muted.
Okay, I'm unmuted. I spend a tremendous amount of time looking and trying to organize coping skills with reference to substance abuse, with reference to sleep, also even with reference to a defusing amount of time when an individual comes home and they have a history of losing their temper with their spouse or their children, to try to figure out a system that they give themselves a few minutes literally to unwind. And then, so a lot of my day-to-day work with patients is really looking at the specifics that actually look at kind of triggers. So it's a sense of where their level of frustration, their level of temper, and their level of the ability to modulate some planning facilities here. I, as an aside, I think it's the level of anxiety I'm feeling with reference to checklists for physicians, as well as teachers carrying guns. We're changing the role of the helping professions, I think, in a dramatic way. I'm not clear where we ought to be intervening with reference to the global safety, both of our children and our teenagers. So I think it's a tremendous additional burden now to ask pediatricians and family practitioners and myself, but I'm pretty conscientious, or was when I was in practice, about taking a history about guns, about what's available, and things like that. One other minor area, I'm often preoccupied with withdrawal syndromes. In other words, if people are withdrawing from alcohol or substances and their level of arousal to kind of both self-destructive and other violent behavior becomes a bit enlarged. So a lot of my work is in detailed history taking and to try to change the various mechanisms to diffuse what in essence the simple way is a loss of temper.
Thank you. So I think all of us could use assistance with making sure that our coping skills are up to speed, because unfortunately it's not going to be all easygoing all of the time. People are going to do things that really push your buttons and make you angry. But what are good ways that we could all potentially respond differently, because that may be role modeling behavior that we don't necessarily want to perpetuate. Ron, what have you seen?
I was going to say, one of the things too that what we always do is when we have presentations, I believe it's 3 now in the past week or week and a half, and that is always having people aware of changes in behavior, the negative changes of behavior, being aware of that, and also encourage people to journal so that we do have some record of this. And again, as Doug, as you had mentioned there, being involved in change direction, to try and to raise the awareness for people to be a little more conscious of this.
Absolutely. So really kind of pushing journaling so you can help keep track of some of those things, but also looking at the awareness. I'm wondering, one of the pieces that I think was very clearly articulated in the presentation is the link that's not quite as strong between mental health and violence. What ways have you seen out in practice that really have tried to challenge that stigma or that perception? I tell my students unfortunately, whenever anything bad happens, wait, see how long it takes for that link or that association to be suggested. Unfortunately, it's usually a matter of sentences, 2-3 sentences at the most.
And usually from somebody that doesn't have any experience working with actual mental illness. And they, throw out terms like, well, they're disturbed, and so things that they don't really have any definition for, but it gets everybody who's watching that or listening to that news broadcast automatically thinking that, well, it's mental illness again.
Yeah, invariably somebody will announce the person was taking the antidepressants, and I don't know the exact statistics, but in my mind's eye, something like 20% of the country is on antidepressants. And most of them are not going out doing these terms. So that doesn't get said on the multiple news. So I agree with you. It's a good question. How do we? It's hard because the media is powerful, and most people that's where they hear it. You hear it 100 times, you're going to believe it, whether it was true or not the first time. So I think we have a tough challenge in all of the medical professions and all of our various degrees. And how do we push back on that and say this is not reality? This is just made up for media, which unfortunately increases the stigma, and then makes it harder for us to say, well, I don't really want to mention that little Johnny did X because I don't want to stigmatize him. Well, no, maybe that's important to get him help. So we, that's that. So it's. I think they work against us in that respect many times. The media.
Any other thoughts on pushing back on the stigma?
Well, I think an awareness, and it's very difficult to share with both ourselves, our families, etc., that there's something very frightening when we're on the verge of losing our temper, that the sense of discontrol and the sense of losing the locus of our own control is so frightening and generates so much anxiety that it's almost an infectious kind of quality that is dramatically enhanced by the media. So that it's a very interesting problem about as we've talked so often here, is refocusing an easy locus of control to both to your mood, your aggression, things like that. So it's a matter of, I think, working very closely with almost everyone in a way to have a sense of being able to generate the fact that a loss of temper or a violent feeling or a mini rage is not mental illness. It's a human construct, and we really need to try to puzzle out how to cope with it.
I think that's a great point. I mean, that is a normal emotion that's going to happen, and making people not afraid of it, but being able to identify it and then act out in an appropriate way to be able to express it, because it's going to happen. There is absolutely no way to avoid it, unfortunately. So, point well taken.
I'd just like to add one little sentence. Pride is concerned with who is right, but humility is concerned with what is right.
That's a good point.
Well said, Jody. So we are about at time. Were there any final thoughts? I really appreciate all of your contributions in our meeting today. Any closing thoughts?
I had one closing thought about the anxiety that has just been risen from Doug about kind of cannabis use and the anxiety associated with, I think, the epidemiology of looking at violence associated with that. I have to rethink that myself and and also in the ability to take a better history.
And I do, I think that that's a great topic to be able to come back to at another time, because there's a lot of different components related to that. So good point. All right, guys. Well, thank you very much for your time today. We really appreciate all your participation. Have a nice weekend.
Yes, travel safely.
Thank you.
Drive
Stay warm.
Great job.
Thank you so much.
See you guys next week.
Bye.
Bye. Great job, Doug.
Bye-bye.